Right, good evening everybody. Welcome to the Health Scrutiny Committee for the 14th of November. I'll start with apologies for absence, but I don't think there are any because I can see everybody who's on the list. There's none at all. No. Declarations of interest. I'll start just to remind everybody, I've said it before, that I'm a public governor of Kettering General. It's just a personal interest though. Anyone else have any declarations of interest? Okay, thank you. Notification of requests to address. Have we got anybody from the public? No, that's none. So we now do the minutes of the meeting of the 12th of September, pages 5 to 8. Are we all happy that they are a true and correct record? Unless, okay.
Sorry, Chair, just to add that I was present at the meeting on the 12th.
Definitely you were, yes. So we'll add your name. Any other matters of record that are... No? Okay. We're all happy to agree the minutes with that small amendment? Okay. I've been asked to slightly swap the order around because there's a consultant going to call in who could only do the early stretch. So we're going to take item 6, the dentistry availability, first, if we may. I don't know who's leading on it because I can see a name on here that isn't here. Perhaps you'd introduce yourself and take it away.
Thank you very much for rearranging the agenda for us. My name's Caroline Golding. I'm Head of Primary Care Services and I look after, my portfolio is pharmacy, optometry and dental commissioning across the East Midlands, which your area is part of. Thank you for the invite. We've pulled together a presentation on screen as well. Rizwana, one of our dental public health consultants who looks after your area, is on as well. So if there are any questions from any members, I have tried to bring my full range of teams so we can answer any question where possible. If I can't, we will take it back and we will come back to members as well. What we wanted to show you through is what we currently commission across the area. We'll talk transparently about the challenges that NHS dentistry is facing, some of the opportunities we hope that the delegation of pharmacy, optom and dental services into ICB's architecture work, and some of the areas we're doing some joint work with public health colleagues to improve oral health. Could I have the next slide, Raj? Okay, so currently within your area, we commission 31 primary care NHS dental practices. We currently commission 3 extended out-of-hours services, and we've got 2 community dental provider sites. So they are the services that look after our most vulnerable patients, our patients with severe learning disabilities, and they provide a number of different services, including services for patients with severe mental health conditions and also patients that require referral in. So those services are not a walk-in and a high street type of service, they are a specialist referral in. We also commission secondary care dental services for patients that need more comprehensive work within the dentistry arena, and we work with both the secondary care trust within your area to provide that service as well. We also commission 2 intermediate minor oral surgery sites. So what that service is, it's a level 2 site and it's meant to be the step between primary care dentistry and secondary care dentistry, and that service is a referral only, and it's for specialised dentists provide that for more complicated extractions or patients that require a little bit more help and support than what we could provide within primary care dentistry. These sites are based on historic need, so they have been developed over years of historic commissioning. Could we move the slide, please? I'm going to hand over Rizwana. I don't know if you're in the meeting. Oh, okay. I don't think Raj. She is in the meeting.
There she is. Hi, can people hear me?
Yes, we can, Rizwana. We just wanted to talk you through the next couple of slides. I don't know if she can hear us. Okay, I don't know. I might have to move the presentation on if she can't hear us engage. here physically, because she doesn't live in the area, and we were only told last week that we were required to attend, so I wasn't able to make the logistical arrangements. However, appreciating that isn't the most opportune thing, what I have offered to the chair and the council is that we'll come again in the early year, and we'll come in person to meet you all as a way of bridging the gap. But we wanted Rizwana involved because she does a lot of the oral health work within her portfolio. Okay, Rizwana.
Hi. Yeah, can you hear me?
Yeah, we can.
All right, okay. Hi, everyone. Sorry, I couldn't hear the first part of the meeting, so I'll just jump in with these slides. So I'm Rizwana Lala, I'm the consultant in dental public health, working with Northants. So what this slide shows is the oral health picture, latest oral health picture that we have from 2022 for 5-year-old children. And it's a series of bar charts, and the one on the left-hand side, the top left-hand side, what it shows is the proportion of children that have dental decay in Northamptonshire. And what you can see is that the blue lines are the kind of regional ICB average, and the dark blue is the England average. And what we can see is 25%, or 1 in 4 children in Northamptonshire experience some level of tooth decay. Now that is comparable with the national picture. Nationally, we see, it ticks around at like 23-24% every year. One in 4 children have dental decay. Now, what we can see on the top right-hand side is those children that have decay. So it's a highly polarized disease. 3/4 of children don't have any decay, but those that do have decay have about 3 or 4 teeth that are affected, and that's consistent with the kind of regional picture, but also the national picture. The lower bottom side, what it's showing is the percentage of children with dental decay in their incisors. So that's their front teeth. Now, we get particularly concerned about the front teeth because, it can lead to kind of bullying and stigma and mental health problems. So it's something that we want to keep an eye on. So in Northamptonshire, you have about 6% of children that have, such severe decay that it's affecting their front teeth as well. That is, slightly lower than the national picture, but comparable with the regional average. Now, on the bottom right-hand side, what we're seeing there is the percentage of children that have tooth decay that's so severe that they're likely to have ulceration and abscess. So these are the children that are likely to be in a lot of pain and missing school and things like that. So again, of kind of quite significant concern in terms of child health and overall well-being. So again, what we see is Northamptonshire, more children experience that kind of the more severe levels of tooth decay compared to the West. But again, the picture is quite comparable when you look at the blue line with the national average, slightly lower than the national average. And next slide, please. So what this slide is showing is the death rates from mouth cancer. Now, this is another kind of in adults, and this is another kind of quite significant part of oral health that we're kind of thinking about in terms of access to dental services, particularly for those more vulnerable groups that are much more likely to access, not necessarily go to the dentist for a regular checkup, but are likely to just attend when they've got dental pain. They're much more kind of vulnerable, we know, from an oral health perspective, to mouth cancer, and also people who are experiencing kind of homelessness in these kind of vulnerable communities. And so the death rates are important because in terms of when you go to see the dentist not only looks at the health of your teeth, but they also look at the health of your mouth. And mouth cancer, it starts off as a very insidious disease. It's quite pain-free, so most people don't notice it. So when you go to the dentist and your dentist notices it, they fast-track refer you to a specialist service. And we know that survival rates significantly improve from 50% to up to 90% with this kind of early diagnosis. So what we see in this picture is the grey bar at the top is showing the England average, and Northamptonshire, it's very similar to kind of the national average. So you've got it says 4.6, and the national average is 4.7 in terms of proportion, in terms of count. So it's very, very similar to the national average. Some of the areas in the region kind of fare quite badly, but again, we want to improve and to make sure that particularly, our services accommodate the needs of these kind of high risk groups in terms of ensuring that they have access to services so that they get that kind of fast track referral.
Thanks, Rizwana. Could we go to the next slide, please? So the team pulled this together to actually look at where we were for dental access in the area. I think being completely transparent, NHS dentistry is nowhere where we need it to be or want it to be, or how hard the team's trying to work. I think, being honest, it was in a challenged position before the pandemic. It's become even more challenged because of a result of the pandemic. I'll talk later on in the presentation on some of the national challenges we're facing, which is not dissimilar in this area, and talk about some of the operational challenges we faced in this area that affect the population here, and what we are trying to do to level up and provide a sustainable service for the future. So this graph shows where we have the most amount of access and where we have the least amount of access. It also shows you where our populations are and how much of the population accesses NHS dentistry. So what we can see in comparison to other areas, that 22% of the total population have access to an NHS dentist. It should be caveated that the NHS has never commissioned to 100% of the population. So unlike GP practices where everyone has a right to go and register, or a choice if they want to go and register, that isn't the case with NHS dentistry. Because of the ability and the offer that some dentists offer the population and their choice to go private. I think the challenges we're facing now is that we have a significant disquiet within the profession to work within the NHS family. Can we move to the next slide and I'll talk about the challenges. So we've tried to split the challenges nationally and also what it means for North Nottinghamshire. To be really clear, we have enough dentists in this country and in this area to provide NHS services. We don't have enough of them working within the NHS family, and that's the simple truth. It's very transparent. If you talk to the profession, that we do a lot of the reasons they don't want to work within the NHS is because the national contract they feel is not supportive to enable them to run not even a profitable business, but a sustainable business. That's something locally that we will try and help and move and nudge and negotiate and try and help shape national teams, but we are slightly limited in our ability and our reach to help shape that national contract reform. We have been waiting for national contract reform for a long time, and the profession is asking for it. We are waiting for the department to publish a dental recovery plan similar to the primary care access recovery plan. We're not sure when the department will be able to publish that. Some of the other issues is the professional discontent with the current contract, in the respect that the way that the contract works, it doesn't generate enough income for them to pay the staff that they require, because it isn't just about having a dentist. You need dental nurses, you need receptionists, you also need enough within the contract to make your premises work as well. So they're the sort of issues we're having. Now, I will say we've had some more acute issues in this area recently than others, but I think it's more of a timing issue in the area, because we experience a lot of issues in other areas. It just seems to be at the moment, within the last 6 to 12 months, we've had some 2 or 3 issues come up, which the team will talk about and talk about what we're trying to do to resolve that for patients. Within Northamptonshire, the areas we're looking at access to services, so us ensuring that we can try and improve access to services. As we've said, currently we've got a commissioned level of service of 22%. That isn't where we want it to be, but it's very hard to try and persuade NHS dentistry to come back in and provide that service. The other areas we're working on for solutions is how we support the vulnerable groups, so our looked after children, our children in care, people that live within the homeless areas and the severe multiple disadvantaged. I will say this is where we are getting some traction. So our community dental service providers work really closely with both my team plus with the ICB and wider partners from within local authorities to really maximise what we have and make sure that the services we do have are focused in the areas we need to. That doesn't mean we always get it right. I do sign off a lot of complaint letters, and I read the letters that are coming from patients that have gone via the MP, so I know the service is not where I wish it to be, but we are working quite hard to try and improve the position for patients, not just here but across East Midlands. And I think the one thing I do want to touch on is the contract handbacks, because we've had some contract handbacks within your area. A number of reasons for different contract handbacks. Some of the profession come and say they can't make it work, they can't make the contract work, so therefore they decide to remove themselves from the NHS family. So that's when you'll see some contracts still remain on the high street, but they offer the private offer instead of the NHS. The other way we've had some issues, we've had unfortunately a sad death of one of the contractors in the area, Mr. Maguire, who unfortunately passed away while providing in service. We've worked really hard with the family and the estate to shore up that provision. Obviously that is an unexpected loss and a very sad loss. What I will say is that when we do have contract handbacks, the team in the ICB go through quite a rigorous process to maintain that access. So one of the things that we work really hard to do is if, say, a contract's handed back, the team are really quick to go out to all the other providers of dental services to say, are you willing to take on additional activity? If they come forward and they're a good quality provider, that activity is dispersed and managed and monitored. If they are not, and we have unallocated access, we do have a strategic plan in the respect of that we are currently in the process of refreshing all the oral health needs assessments for every area within the East Midlands. We haven't done that since the pandemic, and I think it's something that we really needed to do to assess what the need is. For your area, Rizwana's leading that piece of work, and she will be the author as well as with other people working across the partners. What that allows us to do, we will be able to really assess where the need is instead of commission where historically it's been. And once we have that need assessment in place, we will be coming out to committees such as yourself, the Health and Wellbeing Boards, the ICBs, to understand how we start aligning the access deficit we have to the need. Obviously, we've got to work to make sure we can keep as many NHS dentists in the service. That is our first priority. And we are looking at what opportunities working across East Midlands have and how we can sort of explore different ways to increase the dentistry workforce, not just in dentists, but also dental nurses, dental radiographers. We are exploring with the Secondary Care Trust how we can help and work and use their services and their clinical leadership as well across the ICB. Could I have the next slide, please? Okay. This slide talks about some of the opportunities and some of where we are making, because I will be honest, I have been transparent and said it's quite a sort of negative presentation, but we are trying to make strides and we are trying to improve it in a very challenged position. So some of the things we are doing, we've established an outreach pilot for the Northamptonshire severe multiple disadvantaged population. That's starting in the beginning of next year. We've managed to work with our local authority partners to have some recurrent investment to support their oral health promotion programme. So in some ways, some areas of doing toothbrushing packs, working with the health visitors to improve that oral health promotion. We were able to give some more funding, some non-recurrent funding to help some of the food banks to make sure that we can have that in there as well in that provision. What we have done is we've allocated some specific dental clinical leadership to this area. So Steve Claydon unfortunately couldn't be here tonight, but you will meet him in the future if we get invited back. He will come along and he will tell you what he's trying to do across the ICB areas to actually bring the whole dentistry together to make sure that we can work together on that. We're working in ways to getting it right the first time across the secondary care providers to make sure that that area of provision is as sustainable as possible. And 2 weeks ago, nationally, they published the framework for opportunities for flexible commissioning in primary care dentistry. This is one of the tools that the national teams would like us to start deploying. It is about how we can support contractors to remain within NHS dentistry. It allows us to use a bit more flexibility than we did in the dental regulations. It's still brand new. It's just out the door for the last couple of weeks. So we are just assessing how we can use that. But as soon as that's assessed and we talk across the ICB, we will then be deploying the tools we have. We are hopeful that those allowances within that framework will help us when contractors come to us and say they want to leave the NHS family. I can't say that they will solve it, but they'll certainly go some way for us to work on it. Can I have the next slide, please? Okay. The other thing, having been invited to a number of the HOSCs and to a number of the health and wellbeing boards, it is quite evident that there is some myth busting we need to do, and we need to improve our communications with patients, because a lot of patients feel that the way that we commission NHS dentistry is really similar to how we commission general practice, and it isn't. So we've put together some slides that I'm quite happy, I've said to Raj, can share across the local authority to help us with our communications. And it just talks about how patients access it, what happens when contract terminations happen. A lot of patients come to us and they say that I've lost my registration when a practice closes. I don't have a registration. But dentists don't have a registration like you do in a GP. You're there for a course of treatment. So you will go for a course of treatment to maybe have a filling or a tooth repaired. However, because we all associate and probably go to a regular dentist, patients then assume that that's our regular registered dentist, as it does with GP, and that doesn't help patients. And we know we need to improve our communications on that, because when we redistribute activity from a closed practice, the patients automatically think that they have a right to go to that new practice, and that isn't quite working. So that's an area of work we need to take on board. Can I have the next slide, please, Raj? And we've just shared some, we also wanted to share some details about patient charges. We often get a lot of queries through about patient charges and how patients charge, even for NHS services, because there is a patient charge for accessing NHS dentistry. And that's the last page, I think. So I just want to say, I've brought the team here to answer any questions you might have. I will say it's not where we want it to be. There is a long way for us to go. We do need to galvanise our voice to try and improve the national contract offer to help us with the profession. We are open to all ideas and how we maximise the potential we have. We think that the delegation of these services onto ICB footprints will help in the respect it allows us to start having that really detailed place level conversation with GPs, pharmacies and optoms. We just thank you for your time and open to any questions you may have.
Okay, well, thank you for that. I've got a few that I'll start the ball rolling. You said there were 31 practices. I think you're doing an assessment, you said, but I just wondered if they were geographically well spread, because that would, if you want to do them individually, that's fine.
I think on the slide you'll see that map. There's some purple dots that just show you the geographical spread of the practices across North Northamptonshire.
So they are pretty well spread. They are based on historic, and I think what will occur is when we do the oral health needs assessment, we will probably find that there are new areas we need to place access. So that's one of the areas we are looking at, how we support that, how we can support newer providers to go into the areas where we need it.
And we've lost the slides, but there was, when you had the 4 bar charts, there was one that had quite a disparity between the West Northamptonshire and North Northamptonshire. And I just wondered if you'd done any work to find out the cause for that.
I'm going to bring Rizwana on that because she
Yeah.
authored those that piece of data. Rizwana?
Yeah, sorry, I'm just gonna have a look. Yeah, so what we've got, so I think the one that you're referring to is the children who have abscesses and ulceration. So there is a big difference between, well, it looks big because the numbers are actually small. So even a slight difference can look big. So the difference, it's a small percentage of the population. So it's 2.2% in North Northamptonshire, and for West it's 1.3%. So it's less than a percent's difference. But because it's so because the percentages are small, it looks like a big difference. So I mean, obviously we want to be like that number to be 0% because we don't want any children in severe pain. But again, even that 2%, it's still lower than the national average. So does that answer the question?
But it doesn't say what it is or why it is, but I mean, obviously if the figures are small, then just one or two extra can easily.
I think that is some of the work that we're doing around the needs assessment. The most likely thing is that because dental decay is very, very polarized, often what you have is if the polarity is greater, so a small proportion of children have disease, but they also have a lot of disease. So it's a measure or the index of the inequality within the population, and that's the sort of thing that we'll be looking at is what are the levels of inequality and why do we get these kind of pockets of deprivation where the children who experience disease experience it at a much kind of deeper level. So that is what we do in terms of access, but we're also working with the local authority in terms of prevention, and NHS England has provided kind of monies to kind of focus some of that prevention work around toothbrushing clubs within the schools to kind of reduce that kind of level of severity and inequality.
Okay, thank you. The next one I had, you said 22.2% accessing. Is that including private dentistry or is that just NHS dentistry?
No, that's what currently we have commissioned for the population. It is, we have, it's quite hard for us to understand what the provision is in private dentistry because there isn't that regulated need for them to tell us what they're doing. It's something we are exploring though across the network because it's going to impact what the oral health needs say, because what we're expecting is since the last oral health needs assessment and what we're going to be doing in the future, we have more private provision as a result of the results of the pandemic. And also the private provision has changed to whereas before it was a very expensive market to go for private dentistry, the average prices of what private dentistry has come down. So the population, when they do move from being an NHS patient, they could, some people say they don't even notice it until they have a significant piece of treatment and they've gone from having a £30 checkup and an x-ray to a £1,000 root canal, and that's the challenge we're seeing at the moment. We don't have that data. We are asking the national colleagues to see if there is a way we can work with the professions to understand that, because that would then help us get a fuller picture. It would also help us strategically speak to that part of the profession and ask them what it would be for them to come back into NHS dentistry as well, because we have enough of them. I will say we have enough NHS dentists in the country and in this area. We just don't have enough of them providing NHS dentistry.
It may help you strategically, geographically as well.
Definitely.
And the last one I've got, there was some concern really for the looked after children and the children who are part of the Children's Trust, and they have a duty to, they obviously take over responsibility to ensure, are they getting treatment and checkups for the children that they're looking after and that they have under their control in good time, because there was an issue we thought earlier that there was a problem with it.
Okay. We have recognised previously there has been access issues for that population. We have set up a specific task and finish group across the East Midlands to make sure that every looked after child that is in the area has that as a priority, and that the families and the agencies within that know how to access that dental assessment. Rizwana, you're doing some work within that, aren't you, for the looked after children, aren't you? Do you want to come in on that to provide some assurance?
Yeah, so we're doing a lot of work. So what we've done is we've engaged with the local dentists and said to them that, and most of them are, often they don't, when the foster carers ring in, the foster carers often don't say that this is for, this is a dental appointment for a looked after child. And when we've engaged with the profession, what they've said is if they knew, even if their books were full, they would be happy to accommodate the child. So we're doing some work with the nurses in the local authority to get that kind of comms and messaging out, that foster carers make it explicit that they want an appointment for looked after children. We've done some communications with the local dentist. The other thing that we're doing is developing a kind of a buffer to that in terms of an additional pathway, that even after all that, even after they've said it's a looked after child, they're still not getting any traction. There is an additional pathway where the looked after where the kind of the nurse, the registered nurse, is able to give a contact to the foster carer that this is the dentist, that do a direct referral essentially and have that buffer system. So that's the second stage that we're working on.
Okay, thank you. Any other councillors? Councillor McGee, then Councillor Brown.
Sorry, I've got a really sore throat, so I might sound absolutely horrendous. Sorry. Firstly, I just want to say thank you, because, oh my God, this looks like a massive job, and it's quite clear that there are so many other national and governmental structures in place that are perhaps stopping you putting into practice what you can see would make this better. And I think that must be extremely, well, I know as councillor also that is extremely frustrating place to be. So I thank you for your honesty, and I thank you for your work in bending around those systems as much as you can, because it really can't be easy. My first question was really, like, when you were talking about some of the projects put in place, I wasn't quite clear whether they were happening in the East Midlands or whether they were specifically happening here. So like the toothbrush thing that you talked about, the oral health promotion, and working with food banks and things like that, is that happening
That's here.
Yeah.
So everything, even though we work across the East Midlands, everything in this presentation is for yourselves, for what we're doing. We do try and share good practice, so if something's working somewhere and we think we can deploy it, we won't try and reinvent the wheel. We try and get it deployed quite quickly. There are bespoke issues, obviously, and that's why the integration of our services onto the ICB footprints will help us with that place-level discussion. But no, it's happening here.
And in terms of the support that you get from us as a local authority and the ICB here, does that marry up with the support that you get in other areas, or do you think there's more engagement that could be had here, or particular issues that we kind of can raise here more to kind of help you engage and put some of those good practice through?
I think there's always more we can do in the communication and engagement space. I think that should be one of the benefits of moving into an ICB structure, that we can engage more with the population. As much as there's benefits from working across an East Midlands footprint, there are some disadvantages on how you get that messaging down to local communities. The relationship that my team has with the ICB is really strong, and the ICB have welcomed us in completely. So that's been led by the senior leadership of the ICB, and that's something to be thankful for. We are partners and we work on the oral health promotion boards with our local authority partners. So nothing is telling me in comparison to other systems that I would have a concern.
Great, thank you.
Councillor Brown.
Thank you very much. Thank you very much for the presentation. I've got two main questions, if I may fire them both at you at the same time. I don't think they're overly complex, so I'm sure you'll be able to handle them. On children decay, on decay in children, do you link that with social class? And if you do, how does that alter how you intend on improving the situation there and your approaches? And the second one is on the 22% access. How does that compare with the East Midlands? And how does that compare with England? And is there a target that you're hoping to reach, and by when?
Should I take the first question first? And do you want to take the first question, Rizwana?
Yeah, I'll take the first question. So yeah, tooth decay, it marries up with social class, it marries up with deprivation. So what we do is when we do this, when we look at the 5-year-old dental epidemiology, so this data, what we do is we kind of do some detailed analysis and map it with the map it, you know, at ward level as well, so we can see exactly, you know, where the pockets are. And more consistently what we see is the map of deprivation IMD marries up, you know, almost exactly with the maps of child dental decay. So it's very much correlated with socioeconomic group and you know, deprivation.
With regard to your second point about the 22%, nationally we're tracking at 23.96%, so we are slightly below. However, I would say that's probably because of the recent position on contract handbacks, because they were larger. What we find within this area is there are larger contracts. So whereas you might look over the boundary into Leicestershire, where they say, well, Caroline, you've got lots of dentists in Leicestershire, but they've got a lot more smaller contracts, whereas the provision within Northamptonshire, they predominantly are larger contracts. So you're tracking slightly below. You are. I don't have the exact figures, and I will give them to Raj to send through afterwards. You're tracking incomparable to the rest of the East Midlands, though. This does seem to be a position. Do I think... I couldn't say at this moment about what the oral health needs assessment says, because there is one position understanding where our need is, where our most need is. So I can know in 6 months' time I'll be able to come to you and say, I know this is where our need is and this is what the gap is. We need to meet the need. There's one thing doing that. There's also one thing finding the finances in an extremely stretched NHS landscape at the minute. So it is that balance of maximising every part. But what, just to take some reassurance, is that when we do have contract handbacks, we work really hard with the ICB to deploy that activity and access within your local area. It isn't sent outside or outside the border, even though patients do travel for dentistry, they do. We do try and deploy that. What we do have is that any unmet need that we've been able to secure, we'll use that to look at what that means for the oral health needs assessment and look where we need to apply it. We're also hoping that the new regulations laid down by the Parliament recently about the public service regulations on procurement will allow the team more flexibility in being able to offer different opportunities to the market instead of normally going out to a procurement. So we are hoping that we can use the maximum amount of flex within that regulation change instead of having to fully go out and procure services. There still will be some times that we have to, because we are wanting to completely change the service model, because that what meets the new need of the population. But yeah, that's what we'll do in the next tranche of work from next year once we've got the oral health needs assessments signed off.
Okay, thank you. Councillor Lee.
Thank you for the presentation. It'd be nice to have a copy of the slides, because we don't have those. Right, in the area of Kettering and Corby, many dentists have handed up back their NHS contract, and lots of people, residents I know, just do not know where to access an NHS dentist. Is there a way in which residents can find out where you have maybe secured more dentists, where they can go to? Because I am concerned that oral health will fall off a cliff edge, and you've depicted very vividly what happens when those checks are not regularly made. So I'm concerned. So I wonder, is there a way in which we as councillors also can keep track of what is happening to oral mental health to let the policymakers know we really need more NHS dentists? Because with the cost of living crisis, I'm concerned that people won't be able to pay private dentists. Thank you.
I think that's a fair challenge back to us, because there are mechanisms that the NHS architecture enables. Find my NHS dentist. They're not always good if you're not digitally enabled. That's a real struggle. We have trialled in other areas how we get the really good message out that if we've secured a bit more access somewhere, the balance with that is that we end up with queues outside the dentist at 4 a.m. So it's a real balance of how we manage that for patients, because that's not a good experience for anyone, both the contractor. Other councils, other local authorities have used their legislative position to write to the department to articulate the challenges their constituents have. We use the NHS, use our own voice and our way of raising profiles and trying to help shape policy as well. And I think once the delegation of this service is more settled, because we've only just gone in April, I think then we'll be able to really see the true might of how we can change it and see what ability and flexibility we can have. And we're lobbying hard. I'm going to London tomorrow to lobby the National Dental Team to try and get some of the things we think that would work. But one of our mainstays is we've got to get more NHS dentists. We've got to get more dentists into the NHS. Otherwise, we will be coming regularly here and the numbers will not look to improve.
Any others? Councillor Maxwell.
Well, my first question is the fact that certain villages don't even have a dentist around here. To get to a dentist, so for instance, if you're looking at Raunds, which is quite a big town, there's no way whatsoever you'll get into a dentist. There's one dentist, that's it. Where I live in Hyman Rogerton, I think we have two. They're fully booked. You've really got to go to Northampton to get into a dentist. It's bleak, really bleak, for not only for adults but for children. So to get children to a dentist means that they don't go to a dentist. My concern is that if we don't look after children's teeth now, you know, in the future, they're going to get worse. And the other thing is, why when we used to have children getting checkups in school, you know, the dentist would come in and do checkups. I know it's a long time ago, but wouldn't that be one way of finding out who really needs to see a dentist, and that they should be able to go on a regular basis? I think instead of going forward, we're going backwards, and I think that COVID hasn't helped at all. But I think the reason why people don't carry on with being the NHS dentists providing dentist care is the finances. I think that, you know, clearly they actually get more money not doing NHS dentistry than if they do it, because when they do it, NHS dentistry, they've got to do far more to actually make the same amount of money if they weren't, you know, but if they're private, they don't have to. So what are we actually doing to make sure that the government realise that there is a massive problem with young children not getting to the dentist, and also adults just not getting in, or the cost of it? So if you look at a root filling of £1,000. That's a lot of money, and for some people, they don't have £1,000. It's difficult. You either juggle, having your heat on, or having your teeth done, in some cases. So, how do you see the future going forward with dentist care in Northamptonshire?
Really good question. What I hope and what happens may be two different things, but I think the first thing we need to do is work with the profession and use the levelling we have, because the way dentistry services are currently commissioned, they're commissioned on a national footprint, so there's a national framework. There are benefits to that, so that we don't move into postcode lotteries. However, that's difficult depending on where the profession want to be, where they want to live and where they want to operate from. I think that's the first thing we need to do as an ICB, is engage them more and see how we can work with them and work through. I think nationally, I think it will be quite a tough 18-20 months because of potential changes within government. I think we potentially might have to ask ourselves some really difficult questions, because you raised a very good question, is where do you prioritise your need? Where do you if the finances are incredibly tight, where do you focus on them? Do you make that big strategic decision that you focus on children's health and then support other areas of our most vulnerable patients? The other thing we are looking at is one thing we are trying to do is we are going to pilot both here and in Lincolnshire, because Lincolnshire is another, I say this is bleak, Lincolnshire's in a really challenged area. We are going to pilot some foundation training practices that will help some of the foundation training doctors' activity, help the contracts that was removed from the NHS dental contract. So we have taken a view across the East Midlands that we're going to pilot that here, and we're going to pilot that in Lincolnshire to see if that helps us grow the younger dentists, because we need the younger dentists to come back into the profession. So that's one of the things we're going to do. I hope that we can sustain. I'm working hard. The team are really working hard to make sure that every practice we currently have is sustainable and it stays with us in here. And then I'm hopeful, I'm actually optimistic that, we've been able to give ourselves some room and some capacity to redo the oral health needs assessments and really look at where our need is and align the need to where it's needed to be, instead of historically commissioning where it was. So that would be my hope for the next year.
Thank you.
Could I just ask a further question? You see, the thing about the villages is that we don't have a bus service as such. I mean, we do, but we don't, So if, for instance, if you want to spend a day on the bus, that might be fine. But, so I take my grandson over to Oundle, but from where we are, there's no bus service, so you are reliant on a car. But people who don't have a car, they're really stumped, really, in getting to these dentists. And I'm really concerned with the fact that instead of having more dentists, we're having less dentists, and it's about I know it's about bringing young people who are trained to be dentists to set up a practice, but there's two different types, isn't there? There's either, if you're a dentist, you're either paid as a dentist, aren't you, in a practice, or you're part of the practice. So if you're part of the practice, you get more money, and the people who come in to actually salaried dentists, they have to do a lot of work in order to get an income, don't they? There's no, and I think that has a bearing on where they actually operate. I think dentists choose the area, obviously, where they're going to work, but also choose because they're going to get paid at different rates according to where they are. So they might be just doing lots of fillings and not enough for the I think it's a big issue, isn't it?
I think it's a big issue because the profession's changing. So 20 years ago, the dental students coming out of university would do everything, whereas now the profession coming out of universities don't want to do root canals, they don't want to do that complex work. They're asking us to commission more level 2 services for lots of different and really, really valid reasons for them. And I think the other thing with dentistry, the workforce was really impacted with how they were treated during COVID. So during COVID, nationally, their service was shut down. They were put into furlough by the government to help with the pandemic response. They then were asked to open up slowly because we weren't aware of the AGP risk in regards to their practice into how the virus was transmitted. And during that period of time, there were some practices, some of the dental associates were probably not treated very well and decided at that point to move on. So we are dealing with that, we are dealing with the remnants of that. But yeah, it's a challenge, especially for the rural communities. But one area we are looking at, and it is trying to share some good practices, is maybe looking at what hub and spoke models work. We are thinking about how we trial that along the east coast of our area, and that's potentially something that could be something we could look at within to deal with the issue of having a very limited bus service and travelling for the rural community.
Okay. We could be here all day talking about access to services. Mrs. Bethier wanted to come in. Yeah.
Thank you. Thanks, Chair. So, as Director of Public Health, I'm acutely aware of the risks and the issues related to poor oral health. And a couple of observations and an offer, really, for you. So the observations I would make, one is I'm really pleased to see in the opportunity slide your ability to pick up some of those very high-risk groups. So the severe multiple disadvantage group, and I volunteer in a homeless shelter. I am very acutely aware there are people unable to eat because their oral health is so bad, and also things like people's use of substances can be linked with the pain that comes with poor oral health. So I'm really pleased to see that, and an offer from us around when that comes to being rolled out in 2024, the SMD type work. I have direct experience of working in that field, so very happy to support. The other issue I'd raise is about prevention, because prevention is the key here. Where we have limited access to dentistry, it is essential that we have children being educated appropriately about teeth brushing. It's very important that parents understand the importance of that and see it as part of their role, as in their parenting role, to do that with support and with education, which is happening locally. And I'm pleased also to hear that you feel that your relationship with the wider public health world here is supportive of that. But we do need to make sure that all services working with young people have oral health in their mind when they're thinking about how we work with young people going forward. And the final offer is around the needs assessment. Needs assessment is vital. We really do need that information to make sure we get the right targeted approach for our population in North Northants. So if there is information you need, and I haven't met you, Rizwana, but if very happy to have that conversation about how we work with you on that, because that's going to be really essential for us to get the right approach going forward.
Thank you.
Thank you. Councillor McGee.
I know we need to move this conversation forward, but I was just listening and I was thinking some of these things are actually part of the national problems that I was talking about earlier. So I was wondering if, as a Health Scrutiny Board Chair, you might join us in perhaps writing to some of those key policy makers about what we've heard here today and put them forward, because, you know, sometimes I think I forget some people on this board perhaps forget what political party they're in. Can we use this opportunity that we've got here today and what we've learned here today to take that opportunity and to go to policymakers and say, we've listened, we're concerned, and this is what we'd like to do?
I don't think there's any dispute we need more dentists and more accessible dentists. I think everybody's going to argue with that. So perhaps in conjunction with the DPH, we'll look at something. Okay. I'm conscious of time moving on, and we have another considerable item to do. So thank you very much, all of you, for attending and taking it on the chin, so to speak. And yes, we do look forward to having the opportunity to hear what the results of the assessment are and what the plans are coming out of it at a later date.
Have a list of all the dentists in the area. How do we get that? Yeah. Yeah, if you write it down there. That'd be great. Thanks so much indeed. Thank you.
Dorothy,
What?
your microphone.
It's not on? Is it on?
It is. Evening, Trevor. So we're back on to the weighty tome that is the annual report from KGH. Do you want to introduce yourself, Trevor, and your colleagues? Oh, I know who you are.
I should know, I've done this before, but never mind.
You should be aware we are transmitting live on YouTube. So.
Yes. Good evening, everybody. My name's Trevor Shipman. I'm the Vice Chair at Kettering General Hospital, and I have my colleagues here.
Thanks, Trevor. I'm Jane Skippon, Chief Nurse at Kettering Hospital, responsible for nurses, midwives and allied health professionals.
Hello everyone, my name is Richard Wheeler. I'm the Interim Chief Financial Officer at Kettering General.
Sorry, Graham.
Do you want to go through a presentation, or do you want to use the annual? We've all got copies of the annual report, so if you want to use that to go through, or
I think if we just do the presentation briefly, and it will be briefly, and then we'll leave opportunity then for any questions from the annual report. Clearly we'll endeavour to answer as many questions as we can, but there may be things we have to take away and bring back, because there's 148 pages there. So, and having read it all through when it was in its draft form, I do know every word, of course. So thank you for inviting us to present this, and I think this is the annual report for 22-23. We are now well into 23-24, so I think that's an important point to note. As I say, we're going to present a few slides, I think. Whilst that's just going up, I think what's important, we'll pick out some things, first of all, about performance. We'll then be talking about finance. And I will briefly touch on people, and Jane's going to be talking about issues of quality. And then very briefly about sort of a forward look, because an annual plan is not, an annual report is nothing if it doesn't look forward as well as backwards.
Presentation was on the agenda.
The annual report, that one?
Yeah. No, this one. Okay. It was on the agenda.
Oh.
wait for the wonders of technology.
Hopefully, if you've got Teams available.
Yeah, I'm not logged on to your network though.
There we are.
There we are. We're there. Good. Thank you. Next slide, please.
Haven't got that one yet. There we go.
May have heard that before. So, first of all, talking about patient experience. We'd had in previous year some issues, and the CQC had come in and talking about falls. But The report that we've had done more recently on falls has sort of demonstrated how much improvement's been made there. And these changes have caused less patients to have harm. We hope no patient has harm. But I think one of the important things about the falls experience was looking into the multi-layers that we put on our staff in terms of what they have to do. And part of the learning from the falls work was to say, actually, what's the priority? The priority is looking at the patient. Are they likely to fall? And it's not necessarily about layers and layers of paperwork that we've found that the staff had to fill out. So it was refocusing what we're doing and our staff were doing to actually reduce the falls. And Jane might like to touch on that later as well. Another area in terms of patient experience, we have been developing a very strong cardiology service at KGH over a number of years. Now in collaboration with Northampton General, we are centering our excellence at Kettering. That doesn't mean that we aren't doing cardiology at both sites, but it's about where does the leadership come. And actually, for a number of procedures, this means that we have a better quality assurance and we are concentrating our efforts so the patient gets a far better service. And we've got areas there where it's not just about the outcomes, it's about the whole experience, and we have got the equipment at Kettering to deliver that. On the quality, one of the things we aspire to is have outstanding quality of service, and we'll probably come back to this later as well. Our children's service were inspected in December 22 by the CQC, and they rated us as inadequate. We very quickly turned around a number of projects to make sure that the services were safe, but the actual work that needs to be done around children's services, again, Jane will touch on this again later, it's far more than just turning things around overnight. We did turn around overnight the rebuild of the children's department for emergency, but that's only a small part of it. Is how do we get the training into place to make sure the staff and the right number of staff are in place with their qualifications to deliver the service. So children's services certainly weren't where we had hoped they'd be. Next slide, please. On the operational performance, we are in, and it's demonstrated in the report, we are one of the best performing trusts, and jointly with NGH trusts in terms of waiting lists, faster diagnosis for cancer, ambulance handovers, and outpatient waiting times. We've still got a long way to go, and we would aspire to be a lot better than we are. But at the moment, we have actually caught up with the pre-pandemic position. We are running at I think somebody told me the other day, 105.1%, I don't know about 0.1% of the pre-pandemic level. But we have got a long way to go, and we've got a long way to go in areas like diagnostics. We've put in a new service at Corby. We're building a permanent new service at Corby. We've had a little hiccup on the way to delivering that new build in that we had to move the badger set, and we're hoping the badgers don't come back, but that's sort of one of those things that you just trips you up along the way. You don't expect these things. But diagnostics is improving, but still more work to be done around diagnostics. There's more work to be done on A&E waiting times. And just reflecting on that last presentation, one of the areas where we know there's issues around A&E is around paediatrics. And a number of children that come in with severe tooth problems is actually one of the issues we see. It's not the only problem, but it is a problem. So if we can tackle in a more holistic way some of these issues, we have the potential to actually reduce some of the pressures. It's not just about us seeing more patients through A&E, it's actually making sure patients don't need to come to A&E in the first place. And we have need to reduce the number of outpatient follow-up appointments. That doesn't mean patients won't get seen, it's just that sometimes patients have a follow-up appointment to come in to see yet another doctor to have a very simple test that actually could be coordinated with their GP, and these things would actually save more first appointments for more patients to come through and to be seen in a quicker way. On estates and technology, we had the Macmillan Centre opened by Earl Spencer in the year. That has seen 1,200 plus people through its doors. And for those that have needed emotional and information about cancer, it's one of those services that you can't underestimate. It's these little things when people are in the midst of cancer, to getting that access to information, getting somebody to talk to, actually is very, very important. We've had the results of our staff survey. In fact, we're just coming to the end of the new staff survey, literally this week. What I can say is that we've got a significantly better outturn or reporting this year than last year. I don't know about the quality of it, but I do know in terms of the numbers we are close to 50%, whereas last year we were nearer 41%. So we've done work around what we've learnt from our staff, but there is still more to be done. And a lot of that's about coming out of COVID and actually how our staff needed more support than they did before we went into COVID. And to some extent, some might believe some of that support was needed before COVID. What COVID's done is put a spotlight on the support our staff needed. And I mentioned X-ray before, and we have invested 1.2 million in new X-ray equipment in that year. We continue to invest in more equipment. Some of this will be replacement, but replacement equipment, given new technology, means you can be more accurate, you can do more scans, and it enables the better reporting. And the access to robot surgery. Kettering patients do have access to the robot surgery. It's early days on the robot surgery. It's treating a very discrete number of patients at the moment, but it's treating them in a way that we couldn't do before without the robot, and people have had to go a long way, I say a long way, out of county for treatments that we're now able to provide in county. And our aspiration is this is the start. It's certainly not the end of the journey in terms of how we use robots in the NHS. And the ICU rehabilitation project there, garden project, is about how do we just, again, look holistically at our patients. How can people in ITU and their families get some fresh air in what is a very intense period of people's illness? If I can pass on to Richard, please.
Thank you, Trevor. I'm going to give an overview of the financial performance for the year. So Kettering operates with assets of just under £200 million, and Trevor's talked about some of the equipment, obviously the buildings that we've got, and we've got the new hospital programme coming as well. We invested just over £20.5 million in the 22-23 financial year. Some of that was some of the technology that Trevor has just talked about. Also £3 million to purchase and improve facilities to support discharge through the ED department. That included the Naseby extension, the emergency department pod, rapid assessment unit, and also because that was a capital investment, that also yielded a revenue saving over what we had previously been paying. We operate with stock of just over 5 million. That's mainly drugs and medical consumables that we use through the hospital, and we ended the year with around about 4 days of operating cash to support the business. Our income grew by around 3.5% to just under 400 million, and we're employing just under 5,000 staff over the year. So in essence, we're spending more than £1 million a day providing healthcare services to local people. Finance and procurement teams are paying over 70,000 invoices each year, and we are also doing work to improve our some of the payment performance against that, learning some lessons from Northampton on that aspect. The overall financial performance for the year was a deficit that was agreed as part of an overall NHS system position. So Kettering's expenditure exceeded income by £18.8 million. The accounts were audited independently by our external auditors, which for Kettering is a firm called Grant Thornton. So they give an independent opinion to the board that the accounts are a true and fair view, and then they're lodged obviously through a parliamentary process as well.
next slide. Thank you. I'm not going to go through all this. I've put the people up there. I think the important thing to say about people, Richard mentioned we've got close to 5,000 staff. Our 5,000 staff and our over 200 volunteers are what's important for us to be delivering our care. And so there's a range of things there we're doing to support the staff. A number of areas of well-being were developed over COVID, and we've continued with those. They didn't drop away. So we continue to look at our staff's welfare. We continue to support our staff, including things like signposting some of the staff to access advice around debt and how they can manage their money. So we've got a range of things there to enable our staff to move forward. Part and parcel of our work with Northampton General is how can we use the staff who are a scarce resource. We have people think in the NHS, I might say money's a scarce resource. The scarce resource is qualified staff to deliver the care. And if we do not support them, we aren't able to deliver that care. So one of the important things in what we are doing last year and continue to do is how we support those staff. And with Northampton General, how can we make use of staff more flexibly? So that's an important aspect. So how can we make sure that across Northamptonshire we have the right staff in the right place to deliver the right care at the right time for our patients? And you know, the staff are crucial to that. And as part of that, Jane, quality.
Thanks, Trevor. Chair, I was not going to go through the quality account with the quality measures in there. Just to say, really, there were 9 priorities in the for the year, 6 of which were achieved. So we've had no wrong site surgery and...
Sorry, Councillor Tryon, there's no overhead for this one.
Yeah, there's no... it's just part of the quality. It's all in the quality report. So no wrong site surgery, no never events. We've developed psychological safety for staff, embedded our strategy for excellence in care of patients with learning difficulties and autism, and we continue to include patients in the planning of our hospital. And also work really hard to improve learning from deaths processes and also embedding evidence-based care in line with national standards. So they're the 6 of the 9 that we achieved. There were 2 of our priorities we almost did but didn't quite get there. That was about the, some colleagues may have heard it called PSERF. It's the National Patient Safety Strategy. We were hoping to have that embedded from the 1st of October. We're now going to be in line with the national expectation of the 1st of April. That's because of some staffing challenges and also some national guidance that's still coming out. So we're slightly behind where we wanted to be, but we're certainly where we need to be. And then the other one was Mental Capacity Act in relation to do not resuscitate orders. We achieved more than 80% of this target. We've absolutely improved this with our learning disability and autism cohort of patients, but we are still having some of those conversations about do not resuscitate too late in the patient's journey. We're working closely with ICB colleagues and system partners to introduce the respect form so that we can have some of those conversations much earlier on, ideally in the patient's own home or the GP practice where they should be recognised as being on that end-of-life trajectory. So hopefully we will achieve that one. There was one we absolutely didn't achieve, which was how we communicate with our patients. We were really hoping to see a reduction in our complaints around staff attitude and communication, both written and verbal communication. We haven't seen that. But what we have done, and I feel very assured that we will achieve this in the coming year, we've worked really hard on the way we're managing our complaint processes, so our complaints are turning around in much quicker time than they ever have done before, and also the quality of our complaints. That's been recognised by some of our regulators as well, that they're not getting those concerns come back to them. Also in the quality report, you'll see, touching a bit on what Trevor has said, real reduction in our falls with harm. We will always see falls, and we should always see falls in a hospital setting. If we have no falls, it means we're leaving everybody in bed all day. So we do have falls, but what we absolutely need to do is reduce the falls with harm, which is what we've seen. And it was something like 116 days, and we were counting the days down recently with no falls with harm. Also, our pressure damage, pressure tissue damage is right down, that's evident in the pack, and our IPC standards. So I didn't want to sort of touch on that, but I just wondered, Chair, if it's helpful to give a brief update on where we are with children's services, which might preempt some questions or inform some questions.
It's an area particularly concern or interest to the council here.
Yeah, should I give you a brief summary and then happy to take any questions? So as Trevor said, back in December, we had an unannounced visit from CQC. We had a 29A order put in place, which we managed all of the immediate actions that were needed, safety actions, and then we have had very good close workings with ICB, NHS England and CQC to make sure we not only met those immediate safety concerns, but also the other concerns they picked up. Just in case colleagues are not aware, CQC looked at two areas of key line of inquiry, which was safe and well led. Colleagues hopefully know that the CQC came back out to us in May and published their report and their findings in July, which were very different to the report from December. So they absolutely identified some huge improvements that were made. I wasn't in the organisation in December when they visited. But one of the questions I did ask the inspectors on the day was, does this feel different? When you're on the ward, does it feel different? And they overwhelmingly said, yes, it did. Staff were engaged with them. Staff were happy to look at them, involve in conversation. And it felt very different. And it definitely was safe. Because they looked at the two key lines of inquiries again on that visit, so safe and well led again, it means they can't re-rate us. So on that visit in May time, they couldn't actually re-rate our services. But what they do is that Section 29A just sort of sits there. They don't come out to enforce that again. We are absolutely expecting a visit from them anytime and probably by the end of the year. So we'll be ready and welcoming when they do turn up. I share a monthly report with CQC on our progress against those 10 main action streams, most of which now are closed down. We've got some work still to do on our IT and setting up a dashboard, but apart from that, the main work streams have all been closed down. We were weekly reporting. As I say, we're now monthly reporting. We've worked closely with our ICB colleagues, and they've been coming in and doing some quality visits and quality checks for us, but working in partnership. So I might say to them, can you just come in and have a look at this area of safeguarding? I think it's okay, data's telling us okay, but we'd welcome that peer review. So we've been working closely with them about that. We've had regional NHSE colleagues come out and visit our services. We've had some of the local councillors come out and inspect our services, or visit our services, I should say. And I think they've been very pleased with what they've seen when they've come around our children's unit. Happy to take any questions, Chair.
Okay, thank you. I'll open it up to some of the councillors who've got questions. Councillor Lee, go on then.
Thank you. You have preempted my question about continued assurance for the situation, for training in relation to falls, because I think clinical staff, looking at the report online, were less able to do the training and insurance for the children's services for the future. But you have given me assurances. I just wonder with Kettering and the area, Northamptonshire expanding at a higher rate, so the population is growing at a double the national average rate. Isn't there a problem with capacity in the future? Also, particularly the fact that KGH needs to undergo this regeneration that ideally would have been a different hospital. I don't want to get into that, but it's an extremely difficult situation that you have to contend with, not of your own making, I hasten to add.
Yeah, thank you. It's a really good question. We did last December close 4 of our beds on Skylark Ward for safety reasons, which was absolutely the right reason. Those 4 beds remain closed. And that's to ensure we've got the safe staff in and the appropriate qualification of nurses and doctors on our units. And we have done, and we've maintained that level of staffing throughout. Opening those 4 beds, though, would not be our solution. If we open those 4 beds again, we'll just fill them and then we'll still have no beds. So what we need to do is work differently. So we're currently looking at what we're doing with our paediatric assessment unit, which is a side unit, essentially, a side space within the Skylark footprint, and how we might assess children in a different way, not just put them in a bed and assess them, which obviously is far better for patient experience and families, etc. So we're working on that at the moment, and also thinking there is an opportunity to do some virtual appointments for patients. There's also an opportunity to work more closely with primary care to make sure the patients those children that do come in do need to come in. We've put some specialist consultants, so some paediatric consultants within our new paediatric ED footprint, as Trevor touched on. And that's making a difference as well, because you're getting a far more senior paediatric assessment earlier in the patient's journey. So we are able to prevent some of those admissions that would historically have just come into a bed and be monitored or observed for a while. So it's working differently and smarter, not opening more beds.
Councillor Brown.
Thank you, Chair. I've got 3 questions, if I may. First one on the bed occupancy. Within the report, which I should say, by the way, it's a fantastic report. It was really easy for someone like me to follow who's not intimately knowledgeable on these things. So congratulations, it's a really good report. But on the bed occupancy, NHS England target for 93%, and the report said that the systems plan is not to deliver that. I'd like to understand why we're not aiming to deliver that, because there wasn't much in the report on that, if I could. Then I had some concerns on the 31-day wait for first treatment. I know you had a big dip in September and October where you didn't reach target, and it was down to sickness of 1 consultant. That seems to me to be quite a risk, and I wondered if you'd put anything in place, or if there's something that you're able to do to make sure that if you have a consultant, sick for a period of time again, that you don't see that dip in performance. And the third one was on the vacancy rate of 11.7%, which I know this is a problem nationally across, many industries. I just wondered what you guys were thinking of doing that differentiates us, that encourages staff to, instead of working in Coventry or Leicester or Bedford, to, that Northamptonshire becomes the hospital of choice for people to come to work at.
So it's a lot of questions, Councillor Brown. I'm going to take your last one first, and you might have to remind us of the others. So in regard to vacancy rate, obviously the report is only as good as the day the paper was printed. I can give you our current vacancy rates. This was as of Friday. Our registered nurse vacancy is at 9.87%, which is big improvement. As I say, I've not seen it at that level since I've started here. We've always been in double figures, so I was really pleased to see that on Friday. Our healthcare assistant, that equates to about 135 registered nurses, the 9.8%. For healthcare assistants, we're at 10.93%, and that equates to 74 whole-time equivalents. Midwives, we're at 15%, and that equates to 24 whole-time equivalent midwives. Now, all of those midwifery posts, apart from 1.1 and a bit, will all be in post by the end of the year. So that's a huge improvement, and actually puts us ahead in the region of anywhere else. So we've had a huge success with recruiting and retaining midwives, and that's to do with some recruitment posts, retention midwives we've put in post. So it's experienced midwives, they retire and return, and they're looking after new recruits, essentially. So that's been really successful. With our registered nurses, we have not gone for international recruitment. certainly this calendar year. We have done previously. We have got a number of registered nurses in the organisation who have come over with some of those international recruits. We've got about 50. We're working really hard to get those 50 individuals their registration, which we'll do between now and just after Easter probably, which will obviously drive our vacancy rate down again. And then we've also got currently about 60 people in the pipeline against those registered nurse vacancies. And again, that's better numbers than we've seen before. And some of those have got a start date and some of those are just at that offer letter stage. So that's pretty healthy for nurse recruitment. We're doing a few things, like we're offering offering students at the end of year 2 a job. If they're good students, there's no risk to us because you've still got to qualify and you've still got to go through that sort of probation period. So we're doing that. Our real challenge is actually around healthcare assistance, because you can go to Greg's and earn more money than you can against the agenda for change working as a healthcare assistant. That's the reality of it. But again, we've got quite a lot in the pipeline, so it's a healthier picture than it has been. We're not quite there yet, but we are working really hard to get ourselves there. We're offering and working really closely with Northampton and more latterly Leicester, just to, rather than have that kind of competitive, I can go 10 miles down the road and get a better opportunity. Actually, we're all now singing from the same hymn sheet. So we are keeping more local. We are also offering across all specialties more student placements, because we do know that we can keep some of our students. Nationally, there's a challenge because young people go to university, then need to go back to the bank of mum and dad after qualifying. So we do have quite a lot that are quite a lot of students that come to Northamptonshire for training and then go back home. So we're working on how we can support that with accommodation, etc. You spoke, I think your middle question was about having a consultant off sick and how we manage. And that has been a real challenge. We have got a number of fragile services where there's a very small number of consultants with the correct sort of specialty or specialism to be able to manage that cohort of patients. That comes into play with things like dermatology, spinal operations. And there's a small number of services that we're classing as fragile, and we're working with our partner organisation Northampton to see actually where is the best place to provide this service in a really safe and sustainable way. And as I say, more latterly Leicester, so that we can make sure those services don't fall over because a consultant's off sick. So looking forwards, hopefully we are identifying those services and working with partners to make them more robust. And of course the other bit is not moving all of those services to Northampton or to Leicester, but actually having some of those consultants come to us. It's about keeping the services local to home.
Bed occupancy. Wouldn't it be lovely? Key issue with bed occupancy is actually throughput. It's actually getting the patients out at the other end. So it's not about not treating them, it's actually how do we discharge. And I'm not going to go through all the details, but there's some of the patients that just can go home to their own home. They should be discharged relatively easily, the P1s. When we get to complex patients that require either a new placement, because if they're in for more than, I always get this wrong, it's 24 or 48 hours, they lose their old placement and package. All those things add time into the process. We've been working very closely and very well with yourselves on these patients. That's been working very well, but it is about a capacity issue. Capacity both out there in terms of how many places can people move to, and capacity in terms of having sufficient staff in the system to undertake the support to enable the patients to get out, and also to talk to carers and family for them to understand that actually somebody going maybe into an interim rehab place isn't about sending them out to a nursing home forever and a day. So a key part of the issue about capacity is about how we get patients out. It's partly about the numbers coming in, but actually critically, it's about the flow through the hospital of the urgent and emergency patients, those general medicine and other medical specialties, getting them through. That's the critical part of the bed occupancy.
Yeah, and just to add to what Trevor said, we actually start discharge planning at the front door now as well. So we have a discharge team who work from our emergency department. For scheduled care, it's quite easy to predict somebody's end point of discharge, but it is those people that are accessing emergency care pathways that are actually the people that often result in a complex discharge. So we're starting that discharge planning at the front door. And we're also doing a lot of focus around people with dementia, because that is a real challenge for making sure those people are safe to go home. So we've relaunched John's campaign at the end of August, so that we're working much closely with somebody's main carer, which is usually husband, wife or son or daughter, but actually bringing them into the care, so they're working with that patient in partnership with us whilst they're in our care. So it's far more easy to predict what their going home kind of stage is, and that being a safe discharge and them not coming back in. We've got to focus on dementia care, I think.
Sorry, I just wanted to add on the support to staff questions. So as well as the items that Jane was mentioning, we do seek feedback through a variety of mechanisms. We've got a weekly Lex Talk session with senior staff where all staff, that's open to all staff to attend. We've got staff networks again that we're supporting different groups of staff. Obviously, as Trevor said, really great that we're getting a high response rate on the staff survey, because then we can take the feedback from that. And additionally, I think it was at the last board or the one before, we had the annual report from the Freedom to Speak Up Guardian. So again, we're getting that direct feedback from any concerns that staff are raising. So those are also mechanisms that we access.
Okay, thank you. Before I bring Councillor Max, one of the things I had on my list was what you just mentioned. I mean, you've gone to Opal 4 quite a lot recently, and part of that would be the bed occupancy being, in the very high 90s, and a lot of focus coming out on discharge, and obviously that there's been over time this thing where the hospital says the social services aren't ready and social services have their own, so there's this toing and froing which we need to get away from. So are you finding that the support from North Northampton Social Services and other bodies is the right support and is there on time and is giving the right answers for safe discharge? Because that's something obviously we can look at as well.
Absolutely. So I think there's been a real shift over the last 5 or 6 months, I think, in preparation for this winter, about how these patients are our patients as a system. It's not a hospital problem anymore. So we see partners in our, on the KGH footprint every day. And they're working, as I say, starting discharge as early as we possibly can in the patient's journey, and they're joining in with us. So I think we're in the best position we've ever been in, and that kind of passing the hot potato around of who's got ownership of this problem, that's stopped. We have not seen that.
That's very reassuring. Councillor Maxwell.
Well, my first question is going to be, originally we were going to rebuild Ketching General, completely. And it was all going to be brand new, probably off the A14. And now suddenly, from your report, it's not quite the same. It doesn't seem that we're moving forward in getting that new hospital. Is that correct?
I'll answer that one. With my specialist subject.
We have got planned to have Polly come later and sometime later.
Yeah, I won't go into all the details, but one of the critical things about the new hospital build is that we are in part of a national process. My colleague Polly will be able to explain far more about, because she's much closer and been involved in the negotiations with the national team. But every hospital that's in the new hospital programme has got to use a standard design. Those designs are not ready. Or they're only just coming through. So we've got a new process, new set of designs, and the whole thing is being managed at the centre. So we're somewhat in the hands of the centre. What we're trying to do is demonstrate that we actually are more ready than anybody else, that actually we are not as complex as many of the other new builds that are on that scheme. And so how soon it is, I could not say. What I could say is that we are doing a lot of work at the moment around a key element, a sort of provisional element, which is the energy centre, and getting the electricity onto site. Now that's not started yet, and we've still got another stage to go through to get the money, but we are much nearer getting that done. Key point being with a new hospital and any new process, because of net zero carbon, is you need a lot more electricity. We currently maximise our use of electricity through the grid to more than we've got cables coming through coming onto site. So we have got permission with the power company to run new cables into KGH site, and we're just waiting for the funding to be agreed so we can start the work on that, and that would be new substations, and also the second part of that will be the energy centre, which will replace the portable boilers that we've got on the back of lorries that have been there since 2013.
Oh, which is not good.
Yes, if you go in car parks, see there's a trailer there that's been there for years.
The next question is, given the fact that obviously Kettering General, some parts of it are very old, very old buildings, and no parking. When you're coming into an appointment, you can't park, therefore you've got to sort of get someone to drop you off and then carry on. But given the fact that Kettering General now is way beyond its life, seriously, you're struggling with trying to accommodate, are you not, certain procedures because of the fact that the building is not up to standard. Is that correct? Do you think?
Sorry, I think that we are able to accommodate all the procedures that we need to do on site. In fact, our factor there is actually the staff. It's actually given the right clinical staff to do all that we need to do on site, rather than the space. The space is in need of a lot of work to maintain it. I think the point is that we are dependent on national funding to do anything in terms of new build. Now, if somebody would like to write a cheque for more than several £100 million, then we could move forward, because we've been working on the plans, we've been working on the design, we've been working with our staff and our patients on what we need. But the critical thing is that we would need the funding to move that forward. That funding isn't available at the moment. We are in the pipeline for what funding is available, but even with that funding, we would only be opening up a proportion of the new hospital as a new site, with plans for future developments beyond that.
And my last question is that, given the fact that we were one county, we're now split as a county, therefore certain buildings which are in the north belong to the west. And I don't think there's many buildings in the west which belong to the north. But one of the issues is that we had two buildings which were to do with older people coming out and to be rehabilitated into. We've just taken over one in Corby, I gather, recently, last week, I think. And there's one in Rushden that we need to take over, which belongs to the west, which is empty, actually. It takes, I think, 115 people in Rushden. Now, if these were actually sorted out and not PFI, would that not help the hospital? Because one of the biggest issues is bed blocking, isn't it? Do you think?
Yeah, I was going to say, Richard, you're close to that one.
I'm probably close to that. These are the sort of specialist care centre facilities on there. Sorry, and I'm on secondment from Northamptonshire Healthcare, so I've been involved in some of the work. So there is some development of some joint facilities between the Community Healthcare Trust and the local authority, and joint teams doing that. And I know that I'm slightly, probably not entirely up to speed with the latest, because I've transferred over to here. But I know there were some more plans being talked through around that. So yeah, because there is a keenness obviously to use the facilities that are there. So some of that is in place already, and there was discussion about the further use of that. So that is part of the system discussions that are taking place.
And do you not think that one of the biggest issues also is the fact that the cost of this is phenomenal? You know, people coming out of hospital, going into short-term care and then going home. It's just never ending, isn't it, the cost of actually financing that? Do you think that more money should be given so that there are more places coming out of hospital so that people can then rehabilitate and then go home?
I think, I think as the previous dentistry talking about the financial, there's a lot of financial challenges in the NHS, and you know, we've started planning earlier for next year on how we prioritise within all of that. Clearly, flow is a key aspect to all of that. So I think, you know, we're working much more collectively as an integrated care board with other providers, with local authorities, to put those plans in place. There's much more transparency around things like better care fund use, etc., an understanding of how that can support. So I think there's always more to do. We all recognise that, but I think there's a lot more integrated working than there was previously, and obviously that's the key intention of working across the collaboratives.
Finances prevent you from doing this, or there isn't an issue with finances?
I mean, I think the finances are challenging every bit of the public sector, aren't they? You just need to look elsewhere and out wider industry. So we're not immune to that. We suffer cost inflationary pressures as lots of other people do. So yeah, I mean, the finances is very challenging everywhere at the moment. I don't think any of us have the full answer to that.
Thank you.
Okay. Did you want to go in?
I thought just helpful to add some clarity around Thackley Green and Spinneyfields. So we took on the running of Thackley Green back in July, initially opening the service operating in the low 20s in terms of numbers of beds. We've increased that to 35 now. The business case and workings in terms of the premise of taking on the running of Thackley Green, we worked as a system and determined that 35 was the right number of beds for us to operate as a local authority to support that discharge. There is still capacity within the service, so I think it's registered for 51 beds. So we do have an aspiration to have a conversation as a system about how we best use those remaining beds within the service. Spinneyfields, I think, has capacity as well to support 51 people, so it's not in the hundreds of people, and it is empty at the moment.
Yeah.
So hopefully just to clarify those points.
Yeah, thank you.
Thank you.
Is there anybody else before I have a go? It might be worth just informing the committee a bit about the group plans, because and dispel some myths that might be around as well. Yeah,
That's better. Yes, I'll answer that one. So going back 2020-21, Kettering General and Northampton General started talks about how we worked more closely together, how we collaborated together as two separate legal entities. And that's important because for some of us that have been through the NHS for many, many years, one of the things that takes up far too much time is people thought, well, actually, if you merge organisations, you have a better organisation. Somebody put it to me once, if you have two one-star organisations, merge them, you get one two-star organisation. It doesn't work. So what we agreed to do is, how do we collaborate? You heard earlier on talk about fragile services. We'd identified services such as ENT, such as breast surgery, and oncology, where we need to look at a different model of how we provide that across the county. So how do we work together to provide that? How do we make sure that the consultant that works at NGH normally can just walk into a clinic at KGH and his badge will open up the door, that the staff will know him or her? You know, it's how do we make sure we work together? So we started off with this vision of working together as collaboration. And at that point, we also had a view that a good way to move forward to try and attract and recruit more staff of a high quality was to actually move forward also with an academic strategy, to actually give new staff the support to enable them to continue with research and doing other things, as well as providing the normal care. That work has continued. Different people had slightly different visions on it. More recently, from July, 1st of July, we have a new chairman, John MacDonald, who is also chair at Leicester Partnerships. And, sorry, not Leicester Partnerships, sorry, University of Leicester Hospitals. And we have now moved forward with a further collaboration to expand that to include Leicester. So we now have a new chief exec, Richard Mitchell, who is chief exec of Leicester, Northampton and Kettering. 3 separate legal organisations, 3 organisations with 1 chief exec and 1 chair. Those organisations will remain separate organisations, but what we are doing is working out how we collaborate more going forward, how we enable our clinicians to provide better services. And when I say clinicians, I use that in the wider sense. I don't just mean doctors. How do we improve our nursing? We're also looking at how we can make better use of our backroom functions. So how do we actually maybe move forward with a single nurse bank so that people can sign up so they can work in Kettering, Northampton or Leicester and not worry about their qualifications. Have you done your latest update on safeguarding? Well, if you've done it in Northampton, that counts if you work in Kettering or Leicester.
Exactly.
So there's a whole raft of different work streams. In fact, the initial work streams is 11. I'm not going to run through them. But this is about how do we make patient care and the quality of our staff's life better in terms of the provision of care going forward. What it isn't is actually forming a single organisation. And it is about using the pluses in each trust. So if we just take Kettering, for example, Kettering has a much better record on dealing with waiting lists. So actually, how do we support Leicester, who doesn't have that ability, haven't had that ability in the past? How do we use the specialism from oncology at NGH to support patients at KGH? So it's very much a case of how do we work better together? How do we utilise the best? But it is the 3 hospitals working together. I hesitate to say what we're going to call it. There's various names being bandied around, but that's not the point. It's not about a name. It's about how do we provide the environment and the trust to enable people to work together and provide better health care.
I think the important point, as it stands, it's not a merger.
It is not a merger.
That's
and as I say, some of us still have the scars of many mergers we've worked through in the past.
One of the, as you know, I do a bit of medical car driving, and one of the complaints I get regularly from people is that they get called to an outpatients department for something, and then the next day they're called back again for something else, and then a week later back again for something else. And one of the things that would help alleviate, because I suppose consultants are only there one day, so sometimes it's necessary, would be to get the EPR, the electronic patient records, up to speed. So where are we with that?
So electronic patient records, the Kettering General in about 2018 started a procurement of electronic patient record. It's well down the route of implementing electronic patient record. However, Northampton General has just reached the stage where it's in the middle of procurement, and I can't comment on that because it's in the middle of a confidential process at the moment. What we are looking at is whatever systems there are, that they are able to work together and talk to each other. I'm not party to where we are on the Northamptonshire Health Record, but that is part and parcel of how do individual clinicians around the county look at elements, not the whole, of your health records, so that if I pitched up at KGH and I live beside NGH, that actually somebody could look at my health record and say, oh yes, this is why he was in last year and this is what has happened to him. That hasn't been possible to date because each individual health system has been separate and hasn't communicated. So this umbrella, which is the Northamptonshire healthcare system, will enable people to look at that. An early stage of that I've seen working. It's not the full system, having been not working, but being a carer for somebody, and the ambulance crew turned up and said, oh, she's had a number of falls, but she's actually coped at home. She doesn't need to come in. We know there's nothing broken. Whereas otherwise, if they hadn't got that, they would have taken her in on a Friday night to Northampton General, and she would have been there weeks later. So it's in progress, but I can't say where, when, but our aspiration is, and it's part of this wider discussion. So this should not just be about looking at health records in Kettering, Northampton, but actually, if you've got specialists, need a specialist service, you probably go to Leicester. So why can't we look at that record across the system, the wider system? And it may be for certain extremely specialist services, you might go to Nottingham. So why can't Nottingham also see that? It's one of those myths when we talk about the National Health Service. People don't recognise that actually we all have our individual systems.
So you don't have any joined up thinking, so one hospital doesn't join up to another hospital?
It has been attempted,
Really?
Yes.
with a massive failure.
So,
Because
so
it
if
cost
you
us
had a
several
problem and
billion
you went to
pounds.
Kettering, right, and then you had to go to Leicester, Leicester wouldn't know what's going on in Kettering, no?
Not by turning on the computer.
Really? Incredible. So therefore mistakes are made.
But that is what we're working on at the moment, is to try and move forward in that area, because there isn't a reason technically or legally why we shouldn't be able to do that. There are bridges to cross, particularly around the legal side of it, but it's also on the technical side, some of the bridges is, and people don't realise this, the healthcare IT systems are not just sitting there to be sort of bought off the shelf.
Right.
There have been many developed and many failed. And we're learning lessons all the time. So getting it right is important. But that certainly we want to be able to look across from each part of the health service to use that record.
And it's not just the hospitals. I mean, there are a number of times that GPs say, well, we haven't got the letter, we can't find the letter. Whereas if it was electronically there already, they can just look at it. Next one, I spent the day interviewing for New Nets.
Yes, thank you. Thank you.
And one of the things that came up, well, partly because we had this question, was about communication and patient. What the hospital in particular could do to talk to the wider population. I mean, this is partly public health and education, but partly getting people to know what... And also, I think I read in the report that the patient panel doesn't exist anymore. And things like... it used to be that the members had regular presentations that were done out in the community. The previous board secretary did it with topics of interest. All that thing seems to have gone by the wayside, and communication definitely needs to be. What plans or what thoughts have we got on improving the relationship with the wider public? I mean, special interest groups often get heard and seen, but it's the wider public who can often fall by the wayside.
Yeah, absolutely. And we've got a patient experience lead who sits in my team. And from Q3, so when would that have been? September, October, November, that sort of time, has been tasked with which community groups are you going out to speak to this quarter and next quarter, and really planning that around not just populations of obvious needs, so thinking about dentistry, we heard earlier, going out to local play groups, but also thinking about health inequalities and how do we reach those groups of people. We haven't got all the answers yet, but we definitely have a schedule of all the different types of groups within the community that we're going out to see. And it's about understanding and presenting to them some of the options for some of the challenges they may face as a group. One particular group at the moment is pregnant ladies that are smokers. We've got a high proportion of that, particularly in the Corby area. And lots of those ladies have an Eastern European background. So it's how do we go out and reach those? So for that particular group, we've got a midwife that we're employing who is going out and just reaching out to that group of ladies. We know that that doesn't lead always to healthy births for those women. So we need to be focused, but at the same time we do need to be quite general, as you rightly say, Chair, that we still do make sure we're going out to carers groups and everybody that we can do. So we have a plan of who we're going to where, and happy to share that at a later date if that's helpful.
And obviously, I mean, councillors are very keen to know what's going on in their communities and very keen to support as well. And they have networks of people to, because often if the information hasn't got out, we can often help and do that. Increase our...
Absolutely welcome that because we don't have all the answers. So yeah, would really welcome working with colleagues to do that.
I'm glad you mentioned birth because one of the things I had on my list was we had a recent change in the maternity status. Is that a permanent change or is that a temporary change?
So we've had no change in our maternity unit status. What we have had is a change in our neonatal unit service. Yeah. They are, absolutely, Chair, I can see why you confuse them because people often do. But they are two very separate services. So there's been no changes to our maternity services. We have had a recent CQC inspection of our maternity services just in the last few weeks, so we're waiting for publication of that report. In regard to the change of service that you mentioned, our neonatal services were a level 2 unit. They're now a level 1 unit, which means essentially we were able previously as a level 2 to look after babies of 28 weeks gestation that required a high dependency bed. It's not uncommon for us to transfer babies out because we're not an ITU facility or a level 3 facility, so we've always had to transfer babies out that require that. Moving to a level 1 unit means that we can take babies of 32 weeks gestation and older and that don't require an HDU facility. So yeah, that's essentially the change in the service.
Other bits, but the last one I'll do. Is finance really. Got away with most of the evening. I was looking at the plan, and obviously a lot of the assumptions were, well, most of the assumptions went out the window, especially the inflation one and others. And obviously we've got a figure. I think it's 14.7 million. What's the current deficit looking like, and what is able to be done, because obviously it's demand-led service and we all know about demand-led services here. What is able to be done to keep this within the agreed limit?
Yeah, thank you. So we've obviously had some financial challenges coming out of COVID when the funding regimes have changed and added by the pressure, as you say, of inflation last year and also cost inflation this year, though thankfully that's coming down a little bit. We've also got the challenges of industrial action costs as well this year, which has been very significant. So we're going through a reforecasting position at the moment. We are currently in a deficit position at month 6 and we're just kind of finalising the month 7 positions, but we're working with system partners on what we can do to manage that. Obviously critical that we are maintaining patient safety through that and obviously access to urgent emergency care, but we're working within the bounds of what government is asking us to deliver within that. We are doing very well, as Trevor was saying earlier, in terms of elective performance, so we're at 105% of pre-pandemic, which is performing very well against East Midlands comparatives. So in summary, we're kind of working through our updated forecast at the moment and looking at all the options that are available and having discussions with system partners. We haven't concluded all of that work currently, so I can't answer where it's going to end up at that, but it is very challenging, certainly at the moment.
Okay. Has anyone got anything else? No? Okay, thank you very much for your attendance. Oh, go on then. One last one. Okay. You turned it off.
Sorry,
having
I'll turn myself off now. With the recent, obviously, strike action with doctors and nurses, How do you see that going forward with the relationship between the hospital and the financial demands that this has now come about?
Do you want me to answer that? I mean the pay awards are set through the national pay award bodies. The NHS, including NHS England, don't really have a role in that. That's an independent process led by government. So really, we don't have a part to play. Obviously, we have a big set of actions in terms of planning to mitigate strike action where that is. But in terms of kind of pay arrangements, that's something we have no role in solving. So we just have to work within the boundaries that we've got to mitigate that. We're very grateful for patients and populations kind of responding where we've got those pressures on those particular strike days and working with us, because we know it's a big challenge for everybody, and I'm sure we're all hoping that it finds a resolution at some point, but we don't have a specific role to play in that.
And the final question is then, what effect has this had on patients when, doctors don't see patients?
So we know up and down the country, all organisations that have been hit with or had to manage industrial action, that has led to longer waiting lists. So we do know that there are a group of patients that have had to wait. I think we've had to follow the national process around the timing of cancelling patients. I think at Kettering we've worked within those set boundaries, but also been very aware of the impact it has on people that you cancel on the day. So we have tried wherever we possibly could not to cancel on the day. But it has ultimately led to longer waits for patients and disappointment and, not great care because they haven't got the care on the day they thought they would have it.
Sorry, can I just add to that? Because I think one of the things that is often missed in this is many of our admin staff that have had to handle those calls. A lot of patients understand, but some patients actually have not been as kind to our staff. So our staff that have made those calls, many of them have had to suffer a lot of abuse making those calls. And so, we've tried to provide as much support as we can, and we also say this is completely unacceptable. Those staff are relaying a message and trying to help the patients, but that has been a significant issue on the back of the strikes. Cancellations happen anyway, but this is just sort of concentrated that around strike days.
Yes, it all adds to the pressure on staff which they've had to suffer recently. Thank you very much for your attendance and explaining and answering all the questions, and hopefully plan goes to the plan. So I need to talk to you about today. Anybody got any recommendations, questions, thoughts they want to after that? Go on, yeah.
Well, I think, again, it would be constructive for us to come together and let key policy and players know that we've listened to the presentation, we recognise the concerns, and we support staffing moving forward, and perhaps even lobbying to get us further up that list of new hospital funding or whatever it was. I propose that from both conversations that we've had today with both partners, we as a committee write a letter to the relevant people with what we've learned and outline that we would like support for those services. I think that's quite constructive and a good way to end an evening.
Yeah, I mean, I'm aware that a lot of political pressure has gone in already on the hospital, and it's maintained its position as one of the ones that you know is going to be done. There's just with all these things, there's a process of strategic business cases, outline business cases, initial business cases, and goodness knows we had the same thing with the bypass all the time. So we'll see what we can what we can add, but no other nothing else. Okay, so.
I was a bit surprised to hear that one of the issues is the electricity. You know, there is enough power being able to generate to go up to the hospital at present.
Yeah, that's been in plan for a long time. That the energy problem has been known, and that's why they've got the initial £46 million, I think it was, to replace that. So that's you know, all but signed off. Okay, thank you very much. So we're on to the what I think is the last item, the scrutiny work plan on page 163. Did you want to add anything there,
Ben? So just to say that the Scrutiny Management Board is meeting on Monday let's get the date right, Monday the 27th of November. So if as a committee you would like the board to consider any additional items to the work plan, or if you wanted to propose moving any of your health scrutiny items to different meetings, then now is the time to come together and propose that.
I think we had one item deferred, didn't we, which was the ICB, wasn't it? Has that gone into January?
Yeah, so the ICB item is has been deferred until January, and that will feed into the Scrutiny Management Board when it considers its revised forward plan.
It's quite a hefty thing on January. Councillor Best.
Yeah, it may not be for that meeting, but at some future health scrutiny meeting. Can we have somebody come and tell us how things are progressing or evolving in terms of provision of GP services? So access to GPs, getting appointments, the kind of things that we all hear a lot of complaints about. I'm not sure who the right people would be, but if somebody can come and give us an overview of what the plan is and how things are progressing and what the targets are, that will be very useful, I think.
Obviously,
meetings.
Primary care, the right thing would be, it's part of the ICB now, so it may be something we can ask them to focus on in January, unless we've got a separate item coming up with it. Yeah. Yeah, sorry.
No. It's a good list of items, but I see there is, as a suggested topic, culture, heritage and tourism business plan. I don't really see the role of this committee in that. Am I wrong in that? Because we already have such a heavy agenda, so many important things to discuss.
Yeah. Well,
I'm not quite sure whether that
I think that's to do with health and well-being, which we would cover, but the times are against us because obviously this is going to exec on Thursday. We haven't actually got the paper in front, unless you've looked at the exec paper. We haven't actually got it in front of us. So I think that opportunity is lost, really.
Yeah. Okay. Good.
I mean, unless Ben tells me differently. Yeah. We've had a number of. We found this in an EAP the other day that the timings just didn't work for a couple of things. So that's something we need to look at in the management board. Okay. If everybody's, and obviously what we're looking for would be more suggestions for the March meeting, because and May we've only got one item, so we're looking for input there. Councillor McGee.
Chair, thank you. Completely might come across as a little bit random, but it goes off the back of something that we were talking about earlier, and something that I haven't actually delved into in my time on this council. It'd be really interesting to look at our approach to substance abuse that was mentioned earlier, and the strategy that we have to combat that, and where the areas for things like that are. If that's possible to add to the agenda, that would be absolutely brilliant.
Yeah, I'm sure. It's something that is in your remit, I would think, yeah.
Absolutely, and very happy to talk about that. There is an item that I think probably should have come this evening, but somebody, I don't think it was submitted in time, around rough sleeping and substance use as well. And there's some work going on around that in the local patching about and public health funding that. But I'm very happy to come and talk about the enormous amount of work we do on that and to bring that to the committee. Absolutely.
That would be brilliant. Thank you so much. Yeah.
Okay, well, with that, ladies and gentlemen, close the meeting at 9:09. Well, you didn't ask a lot of questions of the hospital. I thought you'd all be